Okay. Physicians of different disciplines underestimate the danger of fluid arrangement. They think they can deal with them, but they don't, or they cannot. In a recent study, we have measured the level of overhydration in patients admitted to the ICU. 98% of the patients are overhydrated. But the most interesting thing is that 5 days after admission, they are still overhydrated. So these patients are always full of fluid. I know that in the ICU they give a lot of fluid to correct for the hypotension, but still these patients are fluid overloaded. And fluid overload may occur as a result of aggressive resuscitation therapies, but persistent fluid overload must be avoided because it does not benefit the patient and it can be harmful. In the septic patient, early volume expansion, the reverse protocol, can be beneficial. But beyond that threshold, when organ failure develops, fluid overload has been shown to be associated with worse outcomes. Studies on fluid overload have been looking at various study populations, only renal replacement therapy and ACI patients, mostly pediatric but also adults, other critically ill populations, septic shock, acute lung injury, and so on. Now, in the pediatric population, we always saw that patients with a high percent of fluid overload at RRT initiation, they have shown an increased level of mortality. And you can see here that patient survivors were always at the lower level of percent of fluid overload. There seems to be a threshold value in the range of 15%. And in fact, you can see here less than 10%, 10 to 20, more than 20, there is a progressive increase in mortality. In the adult, it's the very same. If you use a restrictive strategy, giving less fluid to the patient, you have either no difference or improved mortality or improved oxygenation and outcomes. Now, it has been shown, again, also in the SOAP trial, which are adult patients, that patients with acute renal failure, early or late, non-survivors are always significantly higher in terms of fluid balance in liters per 24 hours. And 1 liter of fluid overload describes a 21% increase in the hazard ratio in this patient. The SOAP investigators have concluded that among patients with AKI, mortality rates were increased in patients with oliguria and in those treated with renal replacement therapy, and the positive fluid balance was an independent risk factor for 60-day mortality. Also, fluid balance is an important factor that determines outcome in patients with AKI who are in an ICU setting. This is further results in patients studied for acute lung injury and ARDS, and once again you see that in this case, we have 50% increase in mortality per liter of fluid overload. And in fact, patients with acute lung injury and ARDS have always a level of fluid balance which is much more positive. We also analyzed what the Picard group has done in San Diego and United States. And again, fluid overload was defined as percent of the baseline body weight at the time of AKI diagnosis and in patient with or without renal replacement therapy. It has been shown to be affecting ICU mortality, ICU length of stay, and renal recovery. And again, you see that patients with fluid overload have a cumulative probability of survival which is less. you can see here that with the increase in fluid overload, you actually increase your mortality. And once again, the separation is quite clear also in patients without renal replacement therapy. So whether you have patient with renal replacement therapy at the beginning, at the end, or non-renal replacement therapy, at the peak serum creatinine or at the admission, the non-survivors are always fluid overloaded. Oh, okay. Not only the amount of fluid overload, but also the quantity of fluid overload is important, and the days, the number of days you spend with fluid overload. So the more time you spend in fluid overload, the more mortality tends to increase. And you see here that when you study this in comparison to diuretic use, patients with restrictive regimens have higher diuretic dose, have less level of fluid balance. Again, 1 liter of fluid overload in this study described a 61% increase in mortality. So our general principle that we described in this book is that patients in the ICU may result frequently fluid overload, especially if AKI is present. General balance should be achieved to attempt to optimize cardiac output, mean arterial pressure, lung function, and tissue perfusion. For example, if the patient with AKI have as common final pathway medullary ischemia, which is functionally initially, but then it becomes sustained by an altered tubular glomerular feedback, you may actually want to try to restore renal blood flow. And in order to do that, you have 3 components: cardiac output, intravascular volume, renal perfusion pressure. Classic management of low cardiac output is to optimize heart rate, preload, afterload, contractility, and the surgical results, considering assist devices. But when you give volume, you have to be careful, because sometimes you end up with a pseudo ARDS due to excessive fluid infusion. If you have a cardiac index greater than 2.5 liters per minute per square meter without inotropes, there is no need to give more fluid. Fluid do not correct for vasodilatation. This patient may require vasopressors. For example, in many of these cases, when we have an altered dysfunction of the heart, we end up with acute kidney injury, what we call cardiorenal syndrome today. And we have hemodynamically mediated damage, exogenous factors like drugs, contrast media, neurohormonal alteration, inflammation. In these cases, we have 2 possibilities. One, that the patient has a low cardiac output state, or it has a significant amount of congestion, or both. So if he has low cardiac output state, you have arterial underfilling, then you have activation of the neurohormonal response and vasoconstriction. If you have an increase in preload and venous congestion, whatever happened goes back to the fact that you have a decreased perfusion pressure in the kidney and you end up with AKI. You have activation of several systems, including sympathetic nervous system, vasopressin, natriuretic peptides, renal angiotensin aldosterone system in case of congestion. In particular, you have arginine vasopressin, which is secreted. That leads to a non-osmotic release, and in presence of activation of V2 receptors, decreased water excretion and sodium excretion with increased urea reabsorption, and leads to permeabilization of the tubular cells, as you can see here, and this leads to overhydration. There is a specific case in patients that are overhydrated, come to the hospital, receive high diuretics or ultrafiltration, they may get kidney damage. Why? because in this patient, congestion itself is somehow decreasing survival. But most of them, when they receive diuretics in the very first days, they have an increase in serum creatinine in the second, third day. And we can study the damage that we can make in this patient using early biomarkers in this moment where we can cause ischemia reperfusion damage. Not here when you have a decreased GFR. So biomarkers can precede the time of diagnosis compared to the clinical diagnosis that you can make. So we propose to manage this patient using the 5B approach. Balance, biomarker, BIVA, blood volume, blood pressure. Let's talk about balance for a minute. You know that body volumes are well established and you may have different compositions, and the hydration status is not just total body water, but is intravascular, interstitial, intracellular, and it depends on the osmolality and tonicity of the fluid. Every day we have a compromise. Compromise between input and output in the patient. But the question that we have to ask ourselves is, in what circumstances? Is AKI present? Is a cardiorenal syndrome present? Do we have sepsis, chronic kidney disease, dialysis? How much fluid should we give? How fast? What type of fluid? Dimitri will speak today about this concept. What physiological targets? And then eventually, how much fluid to remove? How fast? With what modality? Diuretics, ultrafiltration. This is a very important slide that shows that the risk for complications is increased when you have restrictive fluid protocols, because you may actually have organ hypoperfusion and hypotension. But if you have liberal fluid protocols, you also have hypertension, edema, and impaired pulmonary exchange. So renal dysfunction can be due to congestion or to dehydration. And you have a U shape. But look at this. If you have a diseased heart, this curve becomes much more steeper. So your procedure should keep the patient in this very, very narrow window of opportunity for treating hydration. How should we manage fluids in patients who develop AKI? Infusion, diuretics, extracorporeal ultrafiltration. Why are fluids given? Well, sometimes maintenance, medication, nutrition, boluses, diuretics. Diuretics can be given to test renal responsiveness, but they should be discontinued or modulated if there is no response to avoid side effects. Diuretics do not reduce morbidity and mortality. They do not improve renal outcome. Of course, it is much easier to manage a patient that is in a condition of non-oliguric AKI. So today, believe it or not, it's very difficult, especially I must say in cardiology departments or internal medicine, to have a correctly done balance. So there are even electronic systems to record the fluid outcome and urine output, because it's very difficult to have a well-done fluid balance at the end of the day. In many cases, I go to the cardiology department. I don't know if there are some cardiologists here, but I go to the cardiology department and they say, oh, this patient is fluid overload. I look at the chart and he's making urine 3 liters. How can it be fluid overload? But of course, if he receives 4 liters of infusion, that's what makes fluid overload. So we accept the idea that you use early goal-directed therapy for the septic patient. But then remember that as nephrologists, we have to do early goal ultrafiltration therapies in this patient. And our techniques today are very, very sophisticated to allow a very good hemodynamic stability. We can do ultrafiltration, hemofiltration, hemodialysis, hemodiafiltration. We can do isolated sessions, intermittent, daily, continuous. But let me explain to you a few differences. For example, if you do ultrafiltration, you remove 2 liters. With sodium 140, you have removed 280. So, 2 kilos removed, 280 millimoles of sodium. If you do hemofiltration, you can remove 10 liters and replace 8 liters with a different sodium concentration. You still have removed 2 kilos, but you have removed 360 millimole of sodium. So you can manipulate sodium and water separately, which you cannot do that with diuretics. Also, if you do hemodialysis, the presence of diffusion induces hypotonicity in the blood and plasma after treatment, and you have fluid shift into the cells with swelling of the cell, and you have more fluid changes in the intravascular volume compared to what you'd expect. This is not the case in continuous hemofiltration, where you have isotonic removal. It is extremely important to balance and study how much fluid you have removed, what is the rate of fluid removal, what is the blood volume status, the overall hydration status, the cardiovascular function, the tonicity of the fluid removed, and potential errors of prescription and delivery. Remember, we published on the fact that in some cases, errors in fluid balance during renal replacement therapy can become catastrophic, either because you have a positive, insufficient fluid removal or fluid gain, or negative, absolute volume or relative volume, so total ultrafiltration or ultrafiltration rate. So in order to make this more safe, we made a call to all the companies and we said, look, you need to manage this. And all the companies have actually accepted to make a feature in the machine that after 10 alarms override, the machine stops. Because in the past, we found some cases where patients were dead because the alarm override was pushed 75 times. So if you override the alarm, the machine starts again from zero. So you may have error of 20 milliliters, but if you do 10 times, it's 200 milliliters. But if you do 100 times, it can be 2,000 milliliters. So that's the main problem. So in summary, balance is crucial. Use fluid with caution, consider kidney function, use diuretic with the individualized modality. You may be required to remove fluids by ultrafiltration or other CRRT techniques. Treatment with extracorporeal techniques should be timely instituted and accurately performed, and techniques are not all the same. What about biomarkers? I just brought you a very simple example. This is a patient that comes with a very high BNP, very low diuresis, typical acute decompensated heart failure. We try to diurese this patient. BNP goes down, diuresis goes up. You see, very nice diurese, very nice decrease in BNP. But look at creatinine. Creatinine goes up. If in the same patient you also monitor NGAL, you may have an information of what happened when NGAL starts to increase or other biomarkers. So you stop ultrafiltration, you apply the 5B concept, and then you see that the patient actually has no increase in serum creatinine. The same is true for ultrafiltration. You do a significant amount of fluid removal by ultrafiltration. Fantastic, you dry up the patient, but again creatinine goes up. If you measure, again, biomarkers, you can get a warning. You can stop ultrafiltration, and then you actually have no increase in serum creatinine. Why is this important? Because we found recently that even if creatinine does not go up, when you have an NGAL positive situation, even with creatinine negative, dialysis requirement and mortality as outcomes are the same as patients with AKI. So this is important because it brings up the concept that subclinical AKI is still AKI. And you will see probably in this month there will be a paper in Kidney International where we change a little bit the rifle structure, where we will have serum creatinine and urine output on this side of the rifle, while in this side we will have biomarkers. In this case, we will have functional criteria. In this case, we will have damage criteria. What about bioimpedance? I don't know why, but bioimpedance is not used too much in the ICU, while in nephrology we use a lot. There are several means to assess volume status, clinical and monitoring. In the ICU, often you use invasive techniques. In nephrology, we tend to use less invasive technique. We use specifically bioimpedance. By studying these three parameters, resistance, reactance, and phase angle, we can actually build a nomogram that describes exactly when the patient is dehydration, overhydration. And as you can see here, there is a good correlation also with central venous pressure. So this is actually important. When the patients are overhydrated, central venous pressure tends to be higher. So we have today a hydration scale. And we can see where the patient is in the level of hydration scale. But we have to manage this together with the other two B's, blood volume and blood pressure. Blood volume is maintained only if by removing extracorporeal ultrafiltration, you take care of the intravascular refilling. You may need continuous refilling in order not to have significant changes in the blood volume. And that's why we use these machines that tell us exactly what happened. Look at this case. Same amount of fluid removed, 3 liters, 3 liters. But this is what happened in a short ultrafiltration session with the hemodynamic instability and drop in blood volume. This is what happened in a prolonged session of ultrafiltration with CRRT. So there are two reasons why you may have hemodynamic instability. One is because blood volume suddenly drops because this is an overhydrated patient, but you are removing too fast. You are removing excessive ultrafiltration per minute. So you have to go back, redesign your prescription, and then you can carry over a very well-performed session. Your patient is starting to be corrected in the hydration scale until a point in which you still have a hemodynamic instability, but for another reason. This is not alpha angle, it's the alpha 1 angle, and it is due to the fact that the patient is dehydrated, there is no more fluid to take out in this patient. So you have removed too much. In this case, too fast. In this case, too much. And this is an example of a cardiac transplant patient with fluid overload, estimated overload 11 kilos, starts with isolated ultrafiltration. You see hemodynamic instability, many drops in the blood volume. So it starts with the prolonged 8-hour sessions during the day, and you see that the level of blood volume does not change significantly over time. It's still very much overhydrated and oliguric, but in the subsequent days, actually still stable. Hemodynamic is stable. Diuresis start to increase a little bit. The level of hydration is improving. We are getting close to the level of optimal hydration status, even probably a little too much because diuresis has started to increase tremendously, and we end up with this drop in blood volume showing that we should not go over, and in fact the patient of the weight of the patient compared to the beginning, 83, is now 71, and the patient is the right weight. So that's our approach, which is a simple algorithm to remember that balance is crucial, blood pressure and blood volume are fundamental. We can use biomarkers, we can use BIVA to understand better what is the case for overhydrated patient. Thank you very much.